I'm now delighted to welcome Dr. Jen O'Sullivan, who is from Guy's and St Thomas's and Oxford University, who's going to talk to us about the allele burden. Thank you, Jen.
Thanks very much. It's a great pleasure to be here, and thanks for inviting me to speak. I understand that I am abutting the lunchtime, so I will keep this relatively short, and I'm sure everyone's very hungry and sort of keen to sort of end the session, but I'm delighted to talk on this subject that I think a lot of people will be quite interested in. All clinicians in MPN are very interested in, should we be testing allele burdens regularly? And an Adams session did outline, certain data that's supportive of this, which I will briefly touch on. And I'm not going to labour this point, certainly in the interest of time, and get to the meatier section of this, but I think everyone here in the room knows that we have there are 3 driver mutations in MPN, and actually there are additional mutations, as you can see here in purple, that we understand drive disease progression and clonal evolution. So I'm going to cover really primarily the role of the driver mutations in understanding and sort of throughout the disease course of MPNs, looking at where are they relevant in diagnosing the disease, how do we use them to risk stratify you and work out whether someone is in a lower risk or a higher risk disease, looking at both of the driver mutations and the other additional mutations. And I think what most people are excited about is thinking of how are they relevant in monitoring response to therapy or risk of disease progression over time, and should we be tracking these routinely in the clinic? This is just to sort of explain, and just so that we're all on the same page in terms of terminology. So you'll hear various terms, allele burden, and you'll hear variant allele frequency. They're exactly the same. Or you'll hear VAF, which is the acronym for variant allele frequency. And in quite a simple way, it's the number of mutant reads when the DNA sample is sequenced, divided by the total reads that are sequenced. So a sequencer really simply takes pictures of the DNA bases. And if there is a G or a T, or depending on the base, it compares the mutant, the abnormal read, to the total read. So example, if someone tells you your JAK2 is 62%, there's 62 mutant reads at that position, so it's a letter change in the gene over the total number of reads that are present. And similarly in CALR, if you have 60 mutant reads divided by 200, you come out with 30%, if that makes sense. I'm not going to go into all the different assays we have, but just this is an example to outline to you that there's a number of different testing platforms. You've probably heard of NGS and myeloid panels, and more often clinicians and laboratories are incorporating MPN panels, and that's really so that you can capture all of the 3 mutations together rather than laboriously having separate assays, although there is variation across the country. As everybody knows, the JAK2 mutation is the commonest mutation, and it can cause the 3 main phenotypes in MPN, so polycythemia vera, ET, or myelofibrosis. Patients with ET can go on to develop myelofibrosis, very small, a relatively small proportion. This similarly with polycythemia, a slightly higher proportion. And actually, you can have a scenario where ET evolves into polycythemia, and really, we should maybe well be moving towards looking at these as JAK2 mutated MPN, and the same mutation can cause varying phenotypes, and people often don't fall quite tidily into the separate categories, as we know now. Looking onto CALR, which is less common, but in 20 to 30% of patients, it doesn't cause a polycythemia vera phenotype universally ever really. It signals through thrombopoietin and can cause an ET phenotype or myelofibrosis, and again, patients with ET can sometimes progress to myelofibrosis. Can we use the allele burden to determine what is the MPN phenotype in a patient? This was quite a nice, very large study by Jacob Grunfeld in Cambridge, and they did show that patients who have a lower allele burden or heterozygous more often have an ET phenotype as compared to patients who have a higher allele burden, more often a PV phenotype. And thinking about CALR, can you use the allele burden to understand, do you have ET or myelofibrosis? And a bit less clear, but there was a study a number of years ago looking at people who have very low allele burdens with CALR. The majority of CALR mutations tend to live around 30 to 40% the allele burden. So, seeing a less than 20% allele burden is less common. So in this analysis, they saw this in 10 to 15% of the patients They were more often women, and they typically had ET. Can we use the allele burden to risk stratify if someone is going to have a complication or sort of more adverse outcomes? And there are varying studies that have looked at this, and they have shown that a higher allele burden can predict thrombosis, more often venous, not so sure about arterial thrombosis. And similarly, these are all Kaplan-Meier curves that I'm not going to go into huge detail of, but is looking at people who are alive without myelofibrosis versus who've experienced it, and you can see that on this plot, on that far left, with the line coming to the bottom, there was a separation, and patients in this study who had a higher allele burden were more likely to develop myelofibrosis. I would caveat this, however, these are all patients with polycythemia vera. There have been an analysis showing that increasing allele burden does correlate with increased white count, hematocrit, and LDH. And a study published earlier this year did show, and I'm highlighting here what is showing odds ratio, so the odds of developing a complication, and this is looking at thrombosis, and I'm highlighting here the white count. So we know that a higher white count is associated with a thrombosis risk, and a higher platelet count similarly. And the vertical line is the odds ratio of 1, so if the spread of the line is clearly over 1, that's significantly increased odds, so it doesn't cross 1. So whether or not is an allele burden required to determine the risk, or could you use a white count, a simpler and cheaper test instead of that? We'll come on to that in a little bit, looking at some of the cases. So thinking beyond JAK-STAT mutations, can you look at other genomics to predict disease evolution? And I think this is incredibly relevant in the scenario of myelofibrosis. It's less clear in ET and polycythemia vera that really if there's a value in this, but we do know there's additional genetic changes that really inform if myelofibrosis is going to be higher risk and requires intervention, and where someone may benefit from a bone marrow transplant, or lower risk and not. So there have been predictive scoring systems that we really use in the clinic, and I find incredibly valuable when we assess a patient to understand whether someone falls into a lower risk or higher risk. And this is one example, MIPS 70 version 2. And again, this is a Kaplan-Meier plot, and when you divide people into the varying different groups, you can see the people who are lowest risk with the sort of almost horizontal line at the top, with a very good outcome. And then if you have high risk, where you have a number of genetic abnormalities and other clinical parameters such as higher blast count, maybe anemia, you fall into a lower risk group. And that allows us to determine how we manage people, and should you be referring somebody, for example, for a transplant earlier. And just to highlight 2 genetic changes that are not currently captured in these scoring systems, what we know are associated with adverse outcomes, so clinicians certainly would additionally look for these genetic changes. And this is something we do standardly do if someone is younger with myelofibrosis and we're trying to consider how we should best manage them. So Adam, very nicely discussed the MAGIC PV study, so I'm not going to go into the detail and the background of what the MAGIC PV study was, but again, to reiterate that this really was the first time that in a study, this study looking at polycythemia vera, where reducing the allele burden or molecular responses was associated with better outcomes. And this was durable, which is very important. And again, at the stem cell level, this correlated with a reduction in the mutation, which would make you think that there is disease modification potentially going on. These are 2 other studies which agreed with this. I'm conscious I'm showing a lot of Kaplan-Meier curves and they all look a bit repetitive, but Proud PV was led by Jean-Jacques Kelagin in France, replicated this using row-pegylated interferon, which many of you probably know now we can use in the UK with the interferon shortage for Pegasus. And an Italian group again similarly showed that patients who had a reduction in their allele burden did have better outcomes in terms of reduced myelofibrosis and reduced thrombotic episodes. Myelofibrosis patients, there is less data on this, and some of this is historical, where I think there's probably more of a lack of data rather than saying that we clearly shouldn't be doing it. But there are fewer molecular responses observed in the data thus far. There was encouraging data presented at EHA this year that looked at maybe slightly a lower reduction, so looking at 20% reduction, and actually very encouragingly, this was in a phase 3 trial looking at one of the newer agents, did show that if you reduce your allele burden by 20%, those patients had better outcomes, which is encouraging and interesting and hadn't been shown before. What about CALR molecular responses? We actually know less about this. There's less described, but there is work going on within it. But most of the data is with interferon, so this is an example of a study where CALR allele burdens were looked at in patients who were treated with interferon, and they did show a reduction. And interestingly showed that additional mutations outside of JAK-STAT was associated with poorer molecular responses, and uncertain, I think, how relevant that is. But there were no correlations with outcomes in this analysis, so whether or not reducing CALR allele burden correlates with outcomes remains uncertain. So I'm going to come on to some questions and then some cases just for food for thought, I suppose, and how we would practice and look at this in the clinic at the moment, and then how we might start actually addressing some of these questions. So first of all, how often should we be monitoring allele burdens? There is no data and there's no sort of guidelines for us to say it should be done annually or it should be done 6 months. We don't have sufficient data to support that. Well, the current, the guidelines need to be written if that is the case. Should we be tracking non-driver mutations? We do know that in assessing in risk stratifying somebody with myelofibrosis, it's certainly recommended to test this. Whether it should be monitored over a number of years, there isn't clear guidance. I do know clinicians, the practices will vary, but we certainly would, in a younger person, every couple of years, consider checking if there's any change. But typically, if the blood parameters and clinically someone is well and there's no change, usually you tend not to see clonal evolution, but that's not universal. And then should we, if we do track these allele burdens, can we start changing our management strategy? So if an allele burden changes, should we start a therapy? If the allele burden, increases, should we be increasing the dose of a therapy? Or if it reduces, should we be reducing the dose of a therapy? Should we switch therapies? If the allele burden disappears and you can't detect the mutation, should you stop your drug? And if someone has additional mutations, is that then justifying combination therapies where ruxolitinib is the first line recommended for high-risk myelofibrosis, but should it be that if someone has additional mutations, they should be considered for ruxolitinib plus a novel therapy? These are open questions where before I move on to the cases, there is no correct answer. And we don't know the answers to these, actually, even though I know across the country a lot of people are checking allele burdens, but we don't know what we should be doing with them quite. So I have a number of cases just to illustrate where they might fit in and how are we using these to sort of change our practice. So the first case is a 51-year-old patient who had an incidental, and this is we see this quite a lot in clinic. Someone goes to the GP and they get a blood test done and you pick up that there's a blood count abnormality. So this patient had a platelet count of 700. He was fit with no medical history. His allele burden on his diagnostic CALR, because it was done on one of those myeloid panels where they do give you, sometimes the test is a present or absent, but now you often do get an allele burden with the result, was 31%, really typical of CALR. Started aspirin, was monitored for a number of years, and he was a bit older. I can't tell you why he had a repeat, but he had a repeat allele burden, and this was 45%, so it had gone up from 30 to 45, and his platelet count was 820, a little bit higher. 820 in a 57-year-old, we would consider this patient to have low risk ET. So first of all, is the change significant? We don't have that many clinicians. I don't know have we that many clinicians in the room, but I wouldn't mind a show of hands. But to my mind, this change is not significant. No, there is an increase. And would it change your management, and should this? And I think for me in clinic, and someone who is low risk and that we wouldn't be intervening with regardless, particularly with CALR mutations without anything in addition, they do incredibly sort of have a good outlook. And if you look across studies, these are the patients who really do the best. So for me, this wouldn't alter management. So therefore, there in this context wouldn't be a role in monitoring and checking this over time. We'll come on to some slightly more tricky cases. So this is the second case, 65-year-old lady, JAK2 essential thrombocythemia, diagnosed in her 50s. Her baseline VAF was typical of essential thrombocythemia, a bit lower. Started hydroxycarbamide when she turned 61, or turned 60 to 61, and this is a little bit arbitrary, but when a lot of these studies came out, there has to be a way of categorizing and understanding if age is relevant, and 60 65, 60 came out as a cutoff, but she started hydroxycarbamide. She had controlled hypertension, and with hydroxycarbamide, she had a very nice response and normalization of her platelet count. She tolerated the therapy very well. Her allele burden was reduced to 9%. So is this a molecular response, even though it's a reduction? The answer is no. So the definitions of molecular responses, so partial or complete, are based on allele burdens over 20%. When it's under 20%, there's such a low level, reductions and the proportion of reductions, how significant they are a bit uncertain. And is it equivalent to someone, say, having 60% to 30%? We just don't know. So I would say no in this context. And next, would it influence your management? You know, would you say you could reduce your dose? We don't know the answer, and the answer will be no, it's not going to change your management. So, and someone whose platelet count is normalized, checking and monitoring it, certainly there isn't a role in this scenario. The alternative, if this was repeated and her allele burden actually had increased to 38%, you might think, oh, maybe, what could we do? We've checked it. I think universally, again, we don't have sufficient data to say we should alter her dose. Her platelet count is normal, and we know a normal platelet count is associated with better outcomes. So for me, this, again, I would continue the hydroxycarbamide, make no changes, and probably not have tested the allele burden, actually. This scenario, I think, that I'm going to present will become a bit more prevalent, but this is a 48-year-old lady who presented with JAK2 mutated polycythemia. She did have presented with a TIA, not a stroke, but and went a transient ischemic attack, so sort of a preamble to a stroke. She started interferon and aspirin, and she tolerated these very well with her blood count normalizing. You can see her blood results at presentation in the purple table, and her allele burden was 47%. She had a higher platelet count, a normal white count of 9, and had a raised hematocrit and hemoglobin for a woman. She stayed on interferon for many years, tolerating it very well, actually. Had an allele burden performed, and it was 1%, which is really an impressive result. Could you stop her therapy? Now, to understand whether you should stop a therapy, certainly thinking about another related CML, where there have been clinical trials looking at whether you can stop some of those TKIs if someone's in a deep molecular response, you need a clinical trial to justify, saying it's a safe thing to do to stop a therapy, and assuming a JAK2 of 1% means that her disease is controlled and how long it will be. I think in anybody who's had a history of a thrombotic episode, particularly with TIA, you'd find there's few clinicians in the country who would be confident and reassured by a 1% in making a decision to stop therapy. When she had a TIA, 48 is very young, you would assume the probability is that was driven by her polycythemia. So for me, the answer would be no. And the last case is a 50-year-old man. He had a JAK2 polycythemia vera for 3 years. Based on a lack of thrombotic history and being young, he was considered to be low risk. And currently, that's how he would be classified. And management of low risk polycythemia vera currently is venesections and aspirin. Thinking about cardiovascular risks or other reasons why you might say someone isn't low risk, he didn't have any additional cardiovascular risk factors. He was a non-smoker. I do want to flag his blood results. 3 years into therapy, so he has a white count of 13. A show of hands, is that normal or abnormal? Abnormal? Great. Normal? Anyone? Okay. Hemoglobin and hematocrit elevated. Platelet count 520. We happy with that? Is that good platelet count? Okay. And his allele burden 77%, a bit high. Typical of polycythemia, most people have a higher allele burden actually. Should you treat him with cytoreduction? Yes? Show of hands. And who thinks we should stay on venesections and aspirin? Fair play, that's all right. 5 years ago, even not even 5 years ago, you could justify somebody staying on 3 times a year isn't a high venesection rate. You could justify staying on this, but as I showed earlier, could you come on to the next? Does the allele burden, I think, for me, what's most important with the case, does the allele burden influence the therapy decision here? Show of hands for yes. Show of hands for no. I say this because, what I showed earlier, which I think is quite important, is that a higher allele burden is associated with higher white count. And if I didn't have the allele burden, for me, before I come on to that, I think we're treating polycythemia vera earlier. We've increasing data to justify this, but the white count of 13 is higher. So white count over 11 is associated with progression to myelofibrosis, increased risk of thrombosis, similarly with the platelet count. So without the allele burden, I would be suggesting cytoreduction, so I didn't need it in this scenario. There are going to be patients who have a higher allele burden with a normal white count, so potentially you could argue testing it in that scenario. But I think higher venous section rate per year, certainly over 4 per year. Iron deficiency is significant, the effects of it are quite profound, and there's really increasing data of the safety of a lot of the really effective agents for polycythemia. So I think we should be probably treating a lot of people who are classical low risk earlier. So for me, the allele burden didn't influence management in this scenario. I have a comment about Q risk. Yesterday there was some quite nice presentations outlining that there's a new Q risk score, Q risk 4, and that actually incorporates blood cancer diagnosis in that. So whether we should be using something like that typically and sort of standardly in the clinic remains to be seen. I think we need to be assessing cardiovascular risks more objectively and standardly in the clinic and using that to inform decisions about thrombotic risk and should we be intervening, rather than variable, checking with the GP occasionally of your cholesterol or checking your blood pressure occasionally. So Q risk 3 is recommended, but whether we'll start using something like a Q risk 4 and incorporating that known risk that the blood cancers do increase the thrombotic risk and then justifying earlier therapies remains to be seen. So I think, all of those cases were me outlining that there's a lot of uncertainties about whether we should be actually routinely using allele burdens in clinic and what clinicians will it change their management. So with colleagues in the MPN community in the UK, we are setting up a study to start looking at this, and actually rather than clinicians across the country and patients checking their allele burdens and we don't know what we should be doing, is that we should check them, but in the context of a study and try to understand whether they're, what we should be doing with them. So the overarching aim is to understand if molecular responses correlate with clinical outcomes and looking at patients with MPNs on therapies. This is a little bit busy, but not to really overly think about all the secondary outcomes, but the primary outcome is to look at molecular response and stratify that by various outcomes. I think this is quite important because all of the clinical trials you'll see in MPN still use symptoms, spleen reduction, and other clinical parameters of their primary outcomes. And molecular responses are still down in secondary outcomes. So I think, if we want to start using molecular monitoring and justifying changes in outcomes, we need to start understanding, can we use molecular responses in primary, as the first outcome in these studies? So we'll be looking at enrolling quite a significant number of patients across all of the MPN subtypes, with all of the mutation types, and including patients on first-line therapy, second-line therapy. Dr. Alessia Khan in Leeds, who's here sitting at the front, is going to lead all of the molecular analysis up in Leeds, which is a very large laboratory with incredible expertise, particularly in MPN. This is an outline of what the study will look like. So if you enroll in the study at time 0, you'll enroll into your data being annually checked with clinical information. Over a 5-year period, you'll have a blood test, but also for retrospective data. So the majority of people in the room will have had their sample tested at a time point, and in the UK, that's stored for many, many years. So then we will have access to retesting that and going back and looking at some of the clinical information. So actually, you'll potentially have data on patients over 20 years, and that really will allow us to have the power to understand the associations with responses, either reductions or increases and outcomes, which would be very powerful. The study will currently plan to continue for 9 years. Whether or not longer is required remains to be seen. And we would plan to bank, so store cells from a subgroup of patients to, in the future, sort of do analysis in the laboratory to really understand what is the biology driving some of the changes that we see. So with that, thank you. I'm going to finish there.